Imagine this. A creature, a whole foal, being delivered in less time than it takes to, I don't know, brew a pot of coffee. We're talking about normal horse birth, specifically stage 2, the actual pushing part. Usually it's wrapped up in just 15 to 30 minutes. It's incredible. But what happens when that amazing efficiency just breaks down? Today we're taking a deep dive into something called equine uterine inertia. It's a really critical condition, can be life-threatening, where a mare's body essentially struggles or sometimes just fails to finish giving birth. And you brought some fantastic sources for this, really detailed stuff looking at the causes, how it's diagnosed, how vets manage it. So our mission for you listening is to really get under the hood of this whole emergency.
It really is fascinating, isn't it, how fast that biological clock ticks during foaling and how quickly things can go wrong. So yeah, our goal here is to cut through the complexity for you, help you understand the different types of inertia, some honestly quite surprising causes behind it, why diagnosis is such a race against time, and the different strategies vets use to try and save both the mare and the foal. You'll hopefully walk away not just knowing more, but with a real appreciation for how intricate birth is in horses and the massive decisions being made in those moments.
Okay, so before we dive into what goes wrong, let's set the scene. For anyone who hasn't seen a horse birth, which is incredibly fast, walk us through what normal actually looks like.
Right, yeah. Normal equine birth, or parturition, is this incredibly rapid, really coordinated event.
Yeah.
It unfolds in 3 stages. Stage I's is the preparatory phase. It's often quite subtle, might last, say, 1 to 4 hours. You'll see the mare getting restless, maybe looking like she has mild colic, some patchy sweat. And crucially, inside, the foal is getting into position, repositioning itself. It's important to note any disturbance then can actually make this stage longer.
Okay, so keep things calm.
Exactly. Then you hit stage 2. That's the expulsion phase. This is the really high stakes, super time sensitive part we mentioned. It kicks off when the water breaks. That's the rupture of the main fetal sac, the choriolentois. And from that moment, the clock is seriously ticking. Ideally, like you said, foal out in 15 to 30 minutes. As the foal moves down, the stretching in the birth canal triggers something called the Ferguson reflex. That releases oxytocin, which drives those really powerful contractions.
Nature's own accelerator, basically.
Pretty much, yeah. Then finally, stage 3 is getting rid of the placenta, the fetal membranes. They should be out pretty quickly too, usually within about 3 hours after the foal arrives. If not, that's a whole other set of problems. Right, so okay, we've got this picture of incredible speed and efficiency, but when that machinery stalls, what exactly is uterine inertia? What does that term mean?
Well, uterine inertia is a major reason for dystocia. That's the term for difficult birth. And fundamentally, it means the mare's pushing efforts, her expulsive efforts, just fail during delivery. And that's exactly when the clock starts ticking loudest for the foal's survival.
And you mentioned it's not just one single problem, there are different types.
Correct. And telling them apart is absolutely critical for treatment. So first you have primary uterine inertia. This is where the contractions are either totally absent or they're just way too weak to do the job. Even if the foal is normal, positioned right, no blockages. It's like stage 2 labor just fails to really kick off properly, or the strong contractions never start. Sometimes this leads to retained fetal membranes too, the placenta not coming out.
Okay, so the engine just doesn't start, essentially.
That's a good way to put it. Then the second type, which we probably see more often, is secondary uterine inertia. This happens when the uterine muscles just get exhausted, worn out. They've been contracting hard, often for a while, but against some kind of physical blockage.
Like what kind of blockage?
Think a foal in the wrong position.
Yeah.
Maybe a leg back, or the head turned, or maybe the foal's just too big for the mare's pelvis, or even twins trying to come out. The mare tries and tries, strains really hard, but because nothing's moving, the muscles just give up. The pushing stops, or it gets incredibly weak, just from sheer fatigue.
Right, so the engine was running, but it burned out trying to move something stuck.
Exactly. And understanding that difference, primary versus secondary, it's absolutely crucial, because if you misdiagnose it, say you think it's primary, so you give oxytocin to stimulate contractions, but actually it's secondary because there's a blockage.
Oh, no.
Yeah, you could cause the uterus to rupture.
Yeah.
Which is, catastrophic.
Yeah.
So getting that diagnosis right and fast is paramount.
That makes total sense. Knowing why the pushing stopped changes everything. So let's get into the why. What actually causes this failure? It sounds like it could be a lot of different things.
It really is complex. Uterine inertia, it's rarely just one single issue. It's usually this complicated interplay of hormones, metabolism, physical factors, even the mare's environment.
Okay, break that down for us. Hormones first.
Sure. Hormonal dysregulation. We mentioned oxytocin. That's a key hormone for strong contractions. So if the mare doesn't produce enough or her uterus just doesn't respond properly to it, that could directly cause primary inertia. But here's something really fascinating and maybe often overlooked. Selenium deficiency.
Selenium, like
Yep.
the mineral.
Exactly, a trace mineral. It's kind of astonishing. But a severe lack of selenium can completely undermine the whole process. Mares with this deficiency have really weak contractions. And here's the kicker. They often don't respond, even if you give them oxytocin.
Wow.
Research shows selenium is involved right down at the cellular level in how those uterine muscle cells actually contract. It affects specific signaling pathways. So without enough selenium, the muscles just can't, well, they can't grip and push effectively.
Incredible. What else hormonally?
Then there's fescue toxicosis. If mares eat tall fescue grass infected with a certain fungus, especially late in pregnancy, they ingest a toxin called ergovaline. This toxin messes up crucial hormones like progestogens and prolactin, which basically throws a wrench in the works for starting labor on time.
Okay, so hormones are one piece. What about metabolism?
Right, metabolic disturbances. Being overweight, obesity, is a significant risk factor. Fat can actually infiltrate the uterine muscle, making it less efficient. Plus, obesity is often linked to things like insulin resistance and inflammation, which don't help. Then there's hypocalcemia, low blood calcium. Calcium is vital for any muscle to contract. So if calcium levels drop, the uterus just can't contract strongly or maybe not at all. And of course, just general poor condition. Nutritional imbalances, being severely underweight or recovering from illness. The mare might just not have the resources to handle the demands of pregnancy and labor.
Okay, so we've got hormones, metabolism. What about physical blockages? You mentioned those causing secondary inertia.
Yes, mechanical and anatomical obstructions. These are really common causes of that secondary type, where the uterus gets exhausted. Fetal malposition and oversize are probably the most frequent culprits. Like we said, foal's leg back, head turned, or just too big. The mare strains against the impossible, and the uterus tires out.
Right.
Also, uterine overstretching. This can happen with twins, or if there's way too much fluid around the foal. A condition called hydrops. The uterus gets stretched so thin it loses its ability to contract effectively. That can actually predispose to primary inertia too.
So too much stretch is as bad as a blockage, in a way.
In terms of muscle function, yeah. Other physical issues could be uterine torsion where the uterus itself gets twisted, or birth canal abnormalities, maybe scar tissue or tumors, or even an old pelvic injury in the mare. Less common, but uterine adhesions from past infections or trauma can interfere too.
Wow, okay. Anything else contributing?
Definitely. Don't underestimate stress and disturbance. Moving a mare late in pregnancy, unfamiliar surroundings, too many people. It triggers the fight or flight response. That releases adrenaline or epinephrine, which actually counteracts oxytocin. It can delay labor, inhibit contractions.
Wait, so stress can actually stop labor?
Yes. Mares can even seem to voluntarily postpone foaling if they feel threatened or stressed. It's quite remarkable.
That is remarkable.
Also, maternal age. Older mares might just have less efficient systems, maybe some wear and tear on the uterus. And finally, systemic disease in the mare or placentitis inflammation of the placenta can disrupt that whole delicate hormonal balance needed for birth.
It's such a complex web of potential issues.
It really is. And what stands out, I think, is that it's often not just one thing. You might have a physical blockage, but maybe the mare was also borderline low on calcium or a bit stressed. It compounds, which really highlights why good management throughout the pregnancy, good nutrition, keeping her in good body condition, minimizing stress is so important. It's not just about reacting to the emergency. It's about prevention.
Absolutely. So given this complexity, how on earth do you spot uterine inertia quickly? What are the signs vets look for, and just how tight is that deadline for diagnosis?
You're right, the window is incredibly narrow. It demands a really fast, systematic evaluation. No time to waste. When you're recognizing clinical signs, stage I signs can be tricky. They look a lot like mild colic, restlessness, pawing, looking at her flank, patchy sweat, maybe peeing a lot, getting up and down. The key is prolonged stage I without moving on. If those signs drag on for hours and nothing progresses towards birth, or if she shows signs of severe colic, that's a big red flag. Get help.
Okay, and stage 2, when the water breaks.
That's where the sirens should be going off if things aren't happening. Stage 2 starts with the water breaking. Signs of dystocia or inertia then are pretty clear. No real progress pushing the foal out within, say, 10 to 15 minutes of the water breaking. That's not long at all.
No kidding.
Or the mare is straining hard, really strong contractions for more than 30 minutes straight, but no foal appears. Or you see something abnormal at the vulva, maybe just 1 foot instead of 2, or the foal looks upside down, or the head's bent back, or the knees are flexed. Any weird presentation.
Right.
And then there's the red bag delivery we talked about. That bright red velvety bag protruding instead of the water breaking. That's an absolute emergency. It means the placenta has detached prematurely, cutting off the foal's oxygen
Instant emergency call.
instantly. And the mare herself, she might be violently colicky, thrashing, or she could be the opposite, looking depressed, exhausted, with really weak pushes, or none at all.
Okay, so those are the signs. How do vets confirm it? What are the diagnostic procedures?
It's not usually one single test. It's putting pieces together quickly. First is a thorough physical exam. Check her vitals, her hydration, her overall state. Then, vaginal palpation. This is crucial. The vet carefully feels inside to assess how dilated the cervix is, and critically, the foal's presentation, what part is coming first, its position, how it's oriented relative to the mare, and its posture, how its legs and head are positioned. This also confirms if it's a red bag situation.
Okay.
Rectal palpation can also help. Feeling through the rectal wall gives information about the uterus itself, its tone, whether it's twisted, and the foal's general position further inside.
What about seeing inside? Imaging?
Yes, imaging techniques are invaluable. Ultrasonography is key. It lets us check if the foal is still alive and how stressed it is. A foal heart rate dropping significantly, maybe below 180 beats per minute, signals major distress. Ultrasound also shows fluid levels, can help diagnose a uterine twist, and assess the placenta. Radiography x-rays aren't used as often, but can sometimes help count fetuses, especially if twins are suspected, or identify certain obstructions.
And lab tests. Can they help predict or diagnose?
They can. Laboratory diagnostics, particularly mammary secretion analysis, testing the electrolytes in the mare's milk, or pre-milk secretions, is actually considered the most reliable way to predict when foaling is imminent.
Really? How does that work?
You look for a significant rise in calcium, usually above a certain level, like 200 parts per million or 10 millimoles per liter, and potassium, along with a drop in sodium. When you see that pattern, it often means foaling is likely within the next 24 to 72 hours.
That's amazing. So you can be prepared.
Exactly. It allows for planned, attended foalings, which hugely improves the odds if something does go wrong. We also run blood tests on the mare to check electrolytes like calcium, glucose, hormones, and definitely selenium if that deficiency is suspected.
It really drives home the urgency.
Absolutely. Timely diagnosis isn't just important, it's literally life or death. Remember this statistic. Every 10-minute delay in stage 2, labor beyond that critical 30-minute mark, is linked to roughly a 10% increase in foal mortality. And foal survival rates just plummet if delivery gets delayed beyond 40 minutes from when stage 2 started. It's an incredibly narrow window.
That is a terrifyingly fast clock. Okay, so diagnosis made, time is critical. What happens next? What are the priorities and the strategies for intervention?
Right, the goals are crystal clear and always in this order. 1, save the mare's life. 2, save the foal's life. 3, try to preserve the mare's future fertility. Time, as we keep saying, is everything. And I have to stress this. Strict hygiene, aseptic technique, and using tons of sterile lubricant during any internal examination or manipulation is vital to prevent injuring the mare or causing infection.
Makes sense. So what are the main medical interventions?
For primary uterine inertia, remember, that's the weak or absent contractions. Oxytocin administration is usually the first choice. We typically use low-dose protocols, giving small amounts intravenously or intramuscularly, maybe repeating every 10-30 minutes, aiming for more natural-feeling contractions.
But you had that warning earlier.
Yes, and this is critically important. Oxytocin should never be used if you suspect or know there's an obstructive dystocia that's secondary inertia caused by a blockage.
Why not?
Because if you make the uterus contract powerfully against something that can't move, you risk tearing or rupturing the uterus or causing the placenta to detach too early. It can be fatal. It's a direct link between getting the diagnosis wrong and causing severe harm.
Okay, crystal clear. What else medically?
Calcium supplementation is important if hypocalcemia is suspected or confirmed, or just if the contractions seem weak. It has to be given slowly, intravenously, while monitoring the mare's heart closely because it can affect heart rhythm. Fluid therapy is often needed to correct dehydration or metabolic imbalances. Selenium supplementation if that deficiency is proven. And for fescue toxicosis, the main thing is getting the mare off the toxic pasture, or sometimes using preventative drugs like domperidone.
What if medication isn't enough or isn't appropriate, like with a blockage?
Then we move to manual and assisted delivery techniques. The first goal is usually to try and manually correct whatever is wrong with the foal's position. This often involves carefully pushing the foal back slightly into the uterus, repelling it to create space to manipulate its legs or head into the correct position for birth. Any pulling or traction has to be gentle and timed with the mare's contractions, never more force than maybe two people pulling steadily.
Right.
We might do an assisted vaginal delivery, AVD, with the mare standing, usually sedated but not under general anesthesia. This works for simpler corrections. For more difficult cases, there's controlled vaginal delivery, CVD. This is done under general anesthesia, often with the mare's hindquarters slightly elevated. It makes manipulation easier and safer for both mare and foal.
Huh.
But it requires a full anesthesia setup and, crucially, a team ready to resuscitate the foal immediately. This is definitely a hospital procedure.
And if even that doesn't work?
Then you're looking at surgical interventions. The main one is a cesarean section, C-section. This is the go-to when vaginal delivery isn't possible or has failed, especially if you're trying to save a live foal. It's major surgery under general anesthesia. Getting the mare referred for a C-section early significantly boosts the foal's chance of survival.
Is there anything else surgically?
The other procedure, usually considered a last resort and only if the foal is confirmed to be deceased, is a phytotomy. This involves surgically cutting the dead fetus into smaller pieces within the uterus so it can be removed vaginally. It avoids a C-section on the mare, which can sometimes be better for her future fertility, but it carries risks of uterine damage if not done skillfully.
It sounds like managing these cases often needs a whole team.
Oh, absolutely. Successful management is often multidisciplinary. You might need the obstetrician, but also internal medicine specialists, anesthesiologists, critical care specialists for the foal. Think about a complication like uroperitoneum in the foal urine leaking into the abdomen. That foal needs intensive medical stabilization before it can even undergo surgery to repair the leak. It really shows why these complex dystocias, the CVDs, C-sections, phytotomies, they're almost always better handled in a properly equipped hospital setting. Knowing when to refer is crucial.
Definitely sounds like it. So after going through all of this, potentially surgery, what is the outlook? What's the prognosis for the mare and the foal?
Yeah, the prognosis,
Yeah.
it's highly variable. It really depends on what caused the problem in the first place, how long things went on before intervention, and what interventions were needed. For the mare's prognosis, survival after an emergency C-section is actually generally pretty good. Studies show around a 76% survival to discharge rate, which is decent considering the circumstances. But future fertility can definitely be impacted. Interestingly, trying for too long with a difficult vaginal delivery seems to be worse for future breeding prospects than opting for a timely C-section. Mares often do better conceiving if they're bred the season after a C-section, rather than trying again in the same year.
Okay, that's hopeful for the mare, relatively speaking. What about the foal?
The foal prognosis.
Yeah.
That's often much tougher. Foal survival rates are significantly lower. For those emergency C-sections, one study had full survival to discharge down around 13%. That's pretty stark.
13%. Wow.
Yeah, and like we discussed, that delay in stage 2 labor, getting past that 30-40 minute mark, it just dramatically increases the risk of the foal not making it. Hypoxia, lack of oxygen during that prolonged or difficult birth, is a huge factor. It can cause permanent brain damage, leading to dummy foal syndrome, or it can be fatal. Physical trauma during the delivery is also a major risk for the foal.
And what about complications after the birth for the mare?
There's a list of potential complications for the mare. Uterine rupture or hemorrhage are obviously life-threatening. Uterine artery rupture is sadly a known cause of death in older mares after foaling. Retained placenta, if the membranes don't pass within about 3 hours, is very common after dystocia. That leads to metritis, a nasty uterine infection, which can quickly become systemic sepsis and toxemia.
And that can lead to laminitis, right?
Exactly. Laminitis is a major secondary risk if the mare develops toxic metritis from a retained placenta. It's a devastating hoof condition. You can also see vaginal and cervical trauma tears and lacerations from the difficult birth or manipulations, which can impact future breeding. Less common things include bladder issues or nerve damage.
And for the foal, if it survives the birth itself.
Potential complications for the foal are serious too. We mentioned hypoxia and neonatal maladjustment syndrome, dummy foal. Physical trauma, like fractured ribs, can happen. A really big one to watch for after a difficult birth is uroperitoneum. That's urine leaking into the abdomen, usually from a tear in the bladder or the urachus.
And that's life-threatening.
Yes, very. It causes severe electrolyte imbalances, especially dangerously high potassium, which can stop the heart, plus metabolic acidosis and trouble breathing. And even if they survive the initial crisis and surgical repair, there can be long-term consequences. Things like the uroperitoneum recurring or severe internal scarring adhesions forming, which can cause chronic problems. Sometimes, unfortunately, euthanasia is the eventual outcome even after initial success. Early aggressive treatment is key.
What a truly intense deep dive. We've gone from the marvel of a normal, super fast horse birth to the really complex and dangerous reality of uterine inertia. Seeing how so many things, tiny mineral deficiencies, physical blockages, even just stress, can derail the whole process
Yeah.
it's sobering.
It really does underscore how important that proactive management is, doesn't it?
Mm.
Thinking about the mare's health and environment throughout the whole pregnancy, not just reacting when things go wrong.
Mm.
And for you listening, hopefully it highlights the incredible value of that rapid diagnosis, making the right call on treatment quickly and having that integrated veterinary team ready. Those moments are so critical.
Absolutely. So, what does this all mean for you listening? When you think about how something like stress can cause mare to literally pause labor, or how a tiny selenium deficiency can halt such a powerful biological process, it makes you wonder, doesn't it? Given these profound complexities and incredibly tight time frames we've explored, what does this tell us about the hidden vulnerabilities that might exist in even the most seemingly robust natural systems? And maybe, just maybe, could the principles we talked about, early detection, rapid and precise intervention, even in the context of a horse giving birth, offer some surprising insights for critical moments in human health, or maybe other biological systems too? Something to think about, perhaps, until our next deep dive.